So, Namaskar, good afternoon, and a very, very warm welcome to this afternoon session. Thank you so much for being on time and very, very warm welcome and a very happy nursing professional development week. This is the first time I came to know about this. Of course, this is being celebrated in US. Nothing stops us from celebrating ourselves because we are all nurses, and most of the people here, all of you are involved in helping others to develop professionally. Thank you for being that. And today, I was expecting to have Mr. Jaydeep with me in this session, but unfortunately, as all of you know, there's a lot of conjunctivitis and flu going around. So he's not able to make it. So I didn't want to cancel this. So I took this opportunity to talk about, patient safety. Why is it critical for nursing education to include patient safety in that? So I will just start with one question to all of you. You can answer this in the chat box. When you are a patient, if you happen to become a patient, God forbid, you should not become sick. In case you become patient and you enter a hospital, what is your priority? Whether it is satisfaction, good food, or it is safety, safe care. What is your topmost priority? Is it safe care and or is it good food or good ambience? What is that you like to have if you get, hospital service? So the answer is no rocket science, correct? Everybody is answering the same thing. We want to have safety first. So there is no discussion. I don't have to convince to all of you that, why safety needs to be part of nursing education. So just give me a moment. Let me pull up my presentation, which will help me to navigate what I need to discuss. So one second, let me put it on the, okay. I hope all of you can see my slide. If you can see my slide, just say yes in the chat box or raise your, electronic hand. That'll be good enough. Thank you. I hope all of you can see it. Yeah. Thank you. So let's start the discussion. Just give me a minute. Let me. Right. So this is what we were supposed to do today, celebrating Nursing Professional Development Week. I was supposed to have Mr. Jaydeep Herbert, CEO of the Skills Institute, as my guest to have a discussion on innovative solutions to professional development. So we'll have him some other day. We wish him all the best to get well soon. And let me get into what I thought I should be discussing just for about 60 minutes. This is not a class per se, but we are going to talk about why patient safety is critical. I'm sure that all of you agreed that patient safety is most important. And briefly, we will talk about the WHO patient safety curriculum because that is one of the best tool that is available out there if anyone wants to learn more about patient safety. And I will take you briefly through all the chapters of the curriculum. And then I will also share with you a free online education that I have made available in my academy so that you can share with your staff, your students, everyone, they can go and learn and they can give the test online and they can even download a certificate. So these are all innovative solutions which are available, but the leaders, the educators, the clinical instructors need to share this information with your students and your staff so that they can go and avail these, which are available free. WHO has got a lot of trainings which are available free. I continue to teach myself from these sources, without paying much money. And sometimes I do pay and, complete my courses as well. It is only because I am very passionate about patient safety. And I am very sure that you all are equally passionate about patient safety because we all agreed that patient safety is the most important thing to achieve when we are in a hospital. So with that, agreement, let's talk about our own Florence Nightingale talked about the first principle that do the sick no harm. There's not much to talk about it. We all agree on that. So let's see that why is it important? Why patient safety? I think most important thing for all of us leaders is that we should be able to tell the stories, tell the requirement, convince them, because after all, probably all the knowledge is available with all. The question is, why do we then not follow what is available as evidence based practice, the safe practices? Why do we skip that, and then we get into trouble? It is not worth harming a patient. These are some of the stories that I picked up from the internet. Preventable medical errors kill 3-year-old Nora Bostro. Misplaced feeding tube kills 11-year-old baby. In India, recently there has been a story which was coming out of Maharashtra where I think it's Maharashtra or maybe some other state, where scissors have been left inside the abdomen after the cesarean surgery. I mean, only we come to know about the incidents which are splashed on the newspaper. But there are events that do happen within the hospital. That is one big source of learning for all the students and for all the nurses. So let's try to understand that why is it important that we have to focus on patient safety. That's the most important focus area that we all must have, and all the organizations should have. WHO says 4 in 10 patients are harmed in primary and outpatient healthcare. Any idea that how many patients in a hospital or lower middle income country, what is that ratio? What is the ratio of patient harm? Any guess? Any guess from all of you? Any guess? Can put in the chat box. How many patients, what is the kind of ratio where patient harm occurs? Developed countries have got some numbers, and Indian country, which is part of the lower middle income, the number is different. It can be as high as 1 in 10 patients. Can you imagine the kind of risk patients are taking when they are entering our hospital? So if all of you know that in the flight, if 1 in 10 flight might crash, will we ever take a flight? We will not. I'm very sure. We will say, let me go by train, let it take more time. I will go by car. It doesn't matter. Aviation industry is one of the most safest industry. Nuclear industry, I understand. See, sometimes I keep thinking myself that, can aviation and healthcare be compared? I think it cannot be compared because of the unpredictability of healthcare. Aviation is very predictable. We have a ticket, we check in, we go there, we check in the luggage, everything is in queue on time, it keeps on happening, right? Every checklist will work. But it is not apple to apple comparison. That brings us to the point that we are far more accountable. We need to be far more diligent about not harming any patient, because every patient is different. Every diagnosis, there is, thousands of diagnoses, many different patients, so many different speciality, acuity of patients. Within all this complex healthcare delivery system, it is very important, that we must be aware the responsibility that we carry on our shoulders, especially as, faculty members who are grooming the young nurses, as nurse leaders who are leading a team of, nurses. So as you can see on the screen, medical errors is the third biggest killer. And all these things are available from US. We really don't know the quantum of, medical errors in India. I'm not talking only about nursing errors. I'm generally talking about all kinds of errors that can happen when somebody is, receiving healthcare. So knowing that the quantum is so big, isn't it very important that, we should do all that we can to sensitize our own nurses and nursing students so that they understand the accountability, responsibility of, being safe when they are with the patients. And it's also very important for us to impress on the nurses that when they do safer care to the patients, they are also safe. I always used to tell this to my nurses that it is not that the SOPs and the protocols and testing and privileging, all this is being done because we have something against you, that we don't love you. Nothing like that. We definitely love you so that you do safer care so you are not getting into trouble. You are not standing in front of some meeting trying to explain why the mistake happened. I was in one of the hospitals, yesterday. I was visiting for a meeting. I was in the waiting lobby and I could, hear some conversations from the nursing head. Same story like I had many years ago, asking, nurses what happened. You asked for medicine. Did you? I could only get bits and pieces. I don't know the full story. Similar things, like why didn't you escalate when you knew that you are not getting the medicine? So all these, basic things, we need to impress on our nurses because the potential for harm is very huge when someone comes into our hospital for health care. Now you can see here the Sentinel events reviewed by year by source from 2005 to 2020. You can see here the bars, self-reported, other, and media. Though media, of course, is very less. This is all from US, from the Joint Commission. So their self-reported errors are much higher, but you can see the graph. It is not, going much here and there. I mean, it's not flattening out or anything. In India, there is no such graph available anywhere. If you want to find out, what is the quantum of harm that could be happening in our country, we don't know. We really don't know. We don't have one place where all the sentinel events are being reported. Only when that happens, we will know the real story of and what needs to be done in our hospitals. So this is one of my favorite pictures I like to talk about. I'm sure that all of you agree with me that in our hospitals, we all know if there are sentinel events, which is leading to severe harm, it gets reported. Do you agree with me? 100% it gets reported. What does not get reported are this yellow and the green ones, the near miss. It was going to happen, but did not happen. Believe me, my dear friends, if we can capture this near miss and no harm, potentially harmful, nothing happened to the patient, potentially harmful, no harm events, this is never getting reported. Near miss, maybe. I think some of hospitals, they have already started with the best catch. And I mean, appreciating those who are informing that, that this could have happened, this was averted, it's very important. That reminds me of a, potential medication error a nurse, could prevent long time ago when I was the CCU head nurse. So one day, my nurse came and she showed me a, insulin order where the doctor was supposed to prescribe increase insulin to 3 ml per hour. Patient was on insulin infusion. By mistake, he must have written 30 ml per hour. Now, there had been incidents where nurses, without questioning, they will try to increase the rate. It can happen. If you tell me that it will never happen, sorry, it can happen. I have seen very dumb mistakes being made. But that day, that nurse came and showed me the order. And she said, this doctor has ordered this, but this is wrong order. Should I be, following this? So I told her, thank you so much. But for all the administrators sitting here, I was little smart, so I took a photocopy. because I knew that when I call the doctor, he's not going to agree. So I called the doctor. This is happening in Middle East, by the way. So this doctor is sitting in the OPD. So I called him. I said, Dr. John, that, you have written a order which is unacceptable. This is, you have written 30 ml. But no, it is impossible. Send the file to me. And I knew for sure that he is going to correct the order. I have had a lot of such experience, but I have already taken photocopy of the order sheet. I'm sharing these things with all of you so that you are aware. Sometimes you need to be a little smarter when such situations happen. Protect your nurses. I sent the file down, and then the file came. Then he called me. He said, "No, Thankam, I wrote the correct thing. I did write 31st, but then I corrected myself into 3 ml per hour." I said, "Oh." So I didn't tell anything to him. I said, Dr. John, when you come up, I would like to see you. I didn't want to tell all this on the phone because this is Middle East. If I report, then you would have been in big trouble. So I told the nurse that, 3 ml, please continue. He has corrected the order. So then when he came for rounds in the afternoon, I called him to my office and I told Dr. John, please never ever do this again. We all do mistake, but let's not cover it up. I said, I don't expect this from my nurses. Then I definitely don't expect this from any of my doctor colleagues also. So I showed him the photocopy and I said, sir, very clear, you made the correction and you are claiming you did not write this. I said, this is not on. You should have thanked the nurse for bringing that to our attention, protecting the patient from getting harmed. So from that day, obviously, he had huge respect for me and he said, I'm so sorry. I was not thinking. Then we called the nurse. We appreciated the nurse for bringing it to our attention. And sometimes this is very important. Leaders to stand up for the nurses who are doing the right things. That will give more courage for the nurses to talk about, when something is unsafe being done, not only by themselves, from somebody else. It is not about, trying to get after the doctor or get somebody else to get punished. No, we are trying to make the system more safer, right? I'll tell you another story. All of you know that I love to tell stories to make a point. So this happened when I was a nursing head, not a ward in charge. I was a nursing head. So we all have been training our nurses, they should speak up and they should be very empowered. They should take, decisions, we had been all of them. This is what they should be doing. So I'm sorry, jumping the gun. Let me stay there. So the story goes like this. There was a child who was transferred from the ICU. I think it's morning time and I was in the office. So I get a call from my supervisor telling him, ma'am, this child was transferred from the ICU. Suddenly the child started having convulsions. So they tried to call the doctor and the doctor was not reachable. There is a resident doctor, was not reachable. So my specialty nurse, she just ordered to transfer the patient to the ICU back, whichever ICU the child came from. She said, let's transfer the child back. So she called the ICU in charge and then transferred. So for me, it was a very big, nice story. I said, oh, my nurses are now fully empowered. They are taking decision in the interest of the patient. I was very proud. But knowing my Indian mindset of everyone, I kind of anticipated there will be some trouble that might come. So my next call was to the intensivist. I called the doctor and I said, tell me, my specialty nurse transferred the child back. Was that a correct decision? So he said, first of all, you must congratulate her. Then the question comes whether it was right or wrong. It was right. If the child was not brought, he could have been, in trouble. You understand, if the seizures, they cannot get an intensivist to come down and see the child. So it was better to take the child to the ICU. So call happened. Immediately after 2-3 minutes, I get a call from the facility director, who happened to be a doctor also. As expected, the facility director was there, the MS was also there. And I knew what is going to happen. So when I went there, facility director told me, I hear that your nurses took a decision to transfer the patient to the ICU. So I said, yes, sir. It was in the best interest of the patient, and I'm very proud that my nurse did that. Then the MS is telling, how come that they did not ask the doctor? They did try to call the doctor. I'm sure that they had no interest to take the role of the doctor, but they did try to call. They could not, and it was early morning. So it was around 8:30, 8:30, 8:45. So I said, she took the call. I said, we should appreciate the nurse. So then the MS was saying, no, 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 my resident was there and he's telling he never got any call. I said, why are we having this discussion? You always tell that you want the nurses to be empowered. Nurses should speak up. They should take the decisions, not unnecessarily call doctors. They should know why they are calling the doctor. So we talk about it in town halls and everywhere. And when one nurse rises up, then you have all the wrong questions. Then the facility director told me, I need an explanation for this. I said, I'm sorry. My nurse will not write an explanation and I will not write an explanation, because I think this is just unfair. We shouldn't do that. I said, if we do that, none of my nurses who are out there will ever think of taking such a courageous step for the benefit of the patient. I said, I'm so sorry that it is for the benefit of the patient she took the decision. Then why are we wasting time trying to understand who will write the explanation letter? I'm sorry. I said, I will not write, she will not write. Then the FD told, I am going to have an inquiry committee on that. I said, feel free. I said, I'm sorry. You feel free to do that. I said, I'll be in my office if you need me for anything else. Excuse me. Have a good day. I came out of the office. After, in the afternoon next day, some doctors started asking me, Thankam, what is this, inquiry committee for that call? I said, I have no idea. I am not calling the committee. You are being called. Feel free to go find out what happened. So 2-3 days, different doctors. But somehow I knew none of the doctors are going to go for that meeting also. So that the entire discussion and the need for an inquiry committee, it died its own death. But I'm sure even me without telling anyone, nurses were aware of it. And it was such a positive story for nurses. It gave them the confidence that if you have the skills and knowledge, you can stand up for your patient. So that is why it is very important to understand why is it critical that we should know all the aspects of patient safety. I'm very sure that in this 1 hour, I will not be able to tell you everything. And even today, I'm learning about the science of patient safety. It is not that easy. Now, the problem, as stated, 138 million patients harmed by medical errors in medium and low economic status countries. Estimates show that out of every 100 hospitalized patient, 10 patients, 100, 10 out of 100, that means 1 out of 10 patient will be, it is not only by, errors, even acquired infection is equally a harm that is happening to the patient. So infection prevention is very, very critical. Medical errors are the third leading cause of death in the United States. And everybody talks about United States because that's the country that collects data and makes it public. In India, I'm sorry, I don't have any figures. Now, this is another organization, ECRI. I do follow them, and they usually come out with very good papers, So they looked at 2,590 sentinel events. What are the top 3, reasons for sentinel events happening? Human factors. Now, that is a big science. How many of us, are aware of all the human factors that we need to know about when we are leading teams? Second one, very interesting, leadership. It's very important the leadership from top onwards needs to be committed to patient safety. It's very easy to talk about it, ladies and gentlemen. There has to be commitment to have safe practices put in place. Now look at the third one, communication. Tomorrow evening, I'm having another guest, speaking necessity for knowing English, healthcare English. Why is it important? And we know that this is what is happening in Western world. In India, I don't know what else could be the reason, because we don't have such studies to talk about. But I'm sure they are not going to be very far from what I'm showing here. So then we come to patient safety curriculum guide. I would urge everyone here, and this is freely available, you can download it. And this one is specifically created for, college faculty, especially. They have told what activities can be done with students, learn that part of the, there are many different chapters, which I'll be taking, sensitizing all of you. So this is very freely available, and it also talks about many different patient harm stories. You don't have to look at the same story. There are stories available in our own country. You can look at those stories as very much possible. So here you can see that this is just a uh, excerpt from the book itself. So they have created this patient safety education and training is only beginning to occur at all levels. This is at the WHO. Now, this is a mandatory component of nursing and medical education. When I was getting trained as a nurse, not trained on any patient safety aspect. It was part and parcel of all the things that we did, that understood that, we have a responsibility to keep our patients safe. We should advocate for the patient. All these things we knew. But there was no structured curricula or anything like that. Now, WHO has a complete curriculum around this. Now, this is something that we should try to see. Now, this particular curriculum has got all the topics, and it is almost 300 page. So it talks about what is patient safety, why applying human factors is important for patient safety, understanding systems and effect of compassion care. There are some very interesting story, where patients, they get discharged, they go from pillar to post, and the wrong diagnosis happening. Nobody recognize what is the problem. So then it's important that you become a good team player. When these things are trained to the students, when they are in the college, when they come to hospital, they will be better. But mind you, healthcare environment itself is not very aware of all these topics. So there is a need to educate the nurses who are coming to hospital. It will take some time when everybody is going to be aware. But starting point can be the colleges and the schools where students are there now, and then the organizations taking, efforts to educate the nurses, especially the leaders. If they are aware, they can do on the spot teaching, because that is called teachable moments. When I was the ward nurse, ward in charge or the supervisor, there were so many teachable moments. As a nursing head, I do get teachable moments, but not as much as when I am a mid-level manager. So I firmly believe, if I'm the nursing head, if my mid-level managers are well trained and they are well, I can make my care to our patients far more safer. But it is very important. So we struggle with mid-level managers who are not trained to take that responsibility of being a manager, inability to lead a particular team, and then of course the disadvantage of not knowing the science of patient safety. So all these are our own problems which are there existing, solved using quality improvement methods. Yeah, I'm sure that many hospitals, they have efforts in NABH came in. Thank you to NABH for accreditation and some hospitals, JCI. So many of these things, they come into place because there is a need for that to be in place. So because there is a need, I do have a joke that I tell my infection prevention control nurse program. When I do the training, I keep on telling, you will not measure this because the NABH is not asking. We try to measure all the things that NABH is asking. NABH is asking what is mandatorily required. And healthcare being such a complex system, and every system will have different needs. So we need to understand, is there something more that I can do to make our care to our patients safer? It may not be the same from one hospital to the other. Share the stories with the other hospitals and other nurses. Engaging with patients and carers. Now, already part of the curriculum, and this month, Patient Safety Day on 17th of September, and the theme is about elevate the voice. Now I know that is a weak area in our system. No, I will ask you to invite me to your hospital just for 2 hours, and it's a weak area. It's because theoretically we will talk about the discharge planning starts from the day of admission. So technically, it means the discharge education should start from the day of admission. But it does not happen. I know that for sure. I have been a recipient of healthcare in recent times. From the best, there was no effort. The patient should be, or the attendant should be trained or taught what they need to do when they go home. I was the attendant. I was smart enough to initiate things. So if someone tells me that it's not happening, I'm sorry. I don't go and tell everyone, the doctors, that who am I and what am I? I don't tell that. I observe. I observe things. When I take my family, I need to get the best. And in some systems, they knew, still can't help it. That is their process. So imagine that, I'm a patient. I'd been in the hospital for 2 days, 3 days, maybe 4 days, 5 days, whatever it is. When I get discharged, there is an excitement that I'm going home. There's a lot of anxiety that what am I going to do, because the hospital is a safe environment. I was being looked after. I was being given medicine. Now, when I go home. So usually we tend to teach everything to the patient and family on the last day. All discharge education, take the summary and just blah, 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 read it. And I urge all of you, do a project around what is your teach back mechanism. Start auditing the patient just before they go home, after the nurses have finished all their education. Try to check how much of what the nurse told the patient and the family remembers. Whether the nurse has given all the education that was required to be given to the patient when they go home. Some of them, we just think they know anyway. I have very interesting story. I had a call from the surgeon saying that CABG patients are, sent home with very clean, wound. And when they come for OPD after a week for the appointment, the wound is oozing. And my ICN says that the surgeon says, sure, because they don't want to call it as SS. No problems that can happen. So I told my OPD nurse where the patient's dressing is being done. I just wanted to see for myself, what is happening. Then when you have a patient with oozing, I will come down to the OPD. I went down to the OPD. The first thing that struck me was the dress the patient was wearing was so dirty. So I went inside. I asked the patient, you didn't change your dress? He said, no, I was afraid, something will happen to this dressing. I said, okay. So that means you did not take bath? So, what are you joking, sister? I will not take bath. I am so worried about my wound. Now, what to tell about this? I told myself, I called my specialty nurses and said, we have failed. We have failed as a team and we are patients. So we had to drawing board, and then we had to ensure process by which these patients given proper education, and then asking them to teach us back, asking the patient, sir, madam, please tell, what did I tell you? Can you repeat it back to me? Teach me back so that I can be sure that you understood. Another thing that happens, patient is getting discharged, comes. It happened once where the son came and told, no one explained to me what happened. So I said, somebody was there with your father, mother, I don't remember. They have been told. So no, that was my neighbor. He just came to discharge him and bring him home because I was not free. So another learning. Am I teaching the right person? Should I be asking that, are you the person who is going to look after Mr. So-and-so, Mrs. So-and-so at home? It is very important. Let's say my mother is 84 and she is in the hospital. If she I hope she will not get into hospital. That, I am busy. My sister is there. My sister has come from Chandigarh. And I imagine I'm not a healthcare worker. She will listen to whatever she's telling. Then when she passes it on to me, half the things she will lose. This happens. Communication will become incomplete. One more thing is very important to ask. Am I speaking to the right person? Is that the person responsible for care of the patient? We do not ask these questions most of the time. I'm talking about this, to sensitize all of you that, if you want to do something in honor of the WHO patient safety theme, we need to look at this one aspect at least. What is when they go home? Are they equipped to look after themselves? We have a quality indicator, return to ER, return to hospital. It's a quality indicator. We always tend to think very medical. We don't look at the root cause, whether it was lack or, lack of confirmation of the health education or discharge education that was given to the patient. Did the patient understand? Now, my dear friends, those of you are aware of Association of Nurse Executives India, for which I'm a founder member. I'm also the first president. I'm very happy that our association is doing a lot around patient safety. Every month, there is something called Empower Hour, where one incident, which is patient harm or a near miss, is being discussed. And being discussed that what can be done to prevent that. And it's being presented in a very innovative manner, in a role play manner. The recordings are available on the YouTube channel of Annie. You can go and look at this. I keep this, those are all free resources available. And with patient safety curriculum was addressed last year by the Annie Patient Safety Fellows. 22. Every month we looked at one chapter. They all have been recorded and it is available on the YouTube channel of Annie. Now, how many of you are aware of this? If you are aware of this, when you plan your CNE, when you plan your special sessions for your students, why don't you use these resources? Plan it on the calendar. All that the faculty or the clinical instructor or educator needs to do is play the round, and when that is finished, maybe you can give a post test or you have a discussion. What was that being talked about in the video? What are your thoughts? What are we supposed? You lead the discussion. Such experiential learning is going to be remembered by your nurses and by your students. It is not all about just giving, gyan. It does not. Gyan everybody has. I'm very sure all of you are also very gyani sitting here. Why am I doing this? Because I know for sure whatever effort we put is going to be less to ensure patient safety. To say that we are truly safe in our care. It is not just one aspect. There are hundreds of aspects in one system. Whether nurses can assert the system to become more safer. For that, we need to have the right skills and the knowledge to speak up. 9 to 11, infection prevention and control. Believe me, ladies and gentlemen, I have been in this training education. I have given thousands of nurses, nurse leaders, students, and I'm yet to see someone passing the test. So what does that mean? We are not thorough with our I'm trying to mute again. I will remove. If you are not listening to me, I just have to remove. Unfortunately, you cannot disturb the session. The topic 10 is patient safety and invasive procedures. Now, that is another area where errors can happen. And sometimes when errors reach the patient, you can stop, right? And the last topic is improving medication safety. And I'm very sure so much is being done around medication safety. Now, we do have our own challenges in our hospital where we struggle with, new nurses coming in with very little knowledge about medication safety. They are not aware. There are some basic things that we need to tell our nurses. I used to tell my nurses, if you don't know the medicine, don't give it. Make an effort to know your medicine, at least. I know that recent times, some of the medication charts have been modified to help that. I've seen where the medicine's trade name now, ISMP, the Society on Safe Medication Practices, they are talking about certain practices where they say that it is better to ask the doctors to write the trade name and the generic name and the purpose of it. So there are few things that one nurse need to know. What is this medicine that I'm giving? For what purpose this is being given? And what am I supposed to look out for? What should I watch in my patient? So when I was a staff nurse, I did not know all the medicines. It's not possible for one person to know all the medicines in the world. But when I will give a new medicine, which I don't know, I'll ask the doctor immediately, please tell me for why you are giving this patient this. Okay, thank you. Tell me what am I supposed to look out for, watch out for. He will tell. You please keep a watch on the urine output, keep a watch on the heart rate. I'm a cardiac nurse, Slowly you learn the entire, medication, about the specialty that you're working in. So there's a whole lot of responsibility on the nurses' part also. I am addressing the faculty, I'm addressing the nurses, the nurse leaders, but each individual nurse have to own it up to ensure that all the facilitation that is being done by faculty and the nurse and everyone, they need to also, it's like a saying, no, I can take the horse to the water, but I cannot drink the water. Correct? So that needs to be kept in mind. So you can see the number of pages in this particular document. Now this has been, brought into 1 hour session. The video is available. No, I am the same person. Today I'm hosting this webinar as the founder CEO of my own company, Signia Healthcare. But patient safety is very, very close to my heart. I am an ambassador for Patient Safety Movement Foundation, USA. And when I became the ambassador, I was able to facilitate the connection for the association. That's how we have fellowship programs, and his fellowship applications are out also that you can get into that. So now in developing countries, what is that is being told? The top problems that happens in developing countries. Healthcare associated infections, injuries due to surgical anesthesia errors, injuries due to medical devices, unsafe injection practices in blood products, unsafe practices for pregnant women, unsafe practices for newborn. Now, this is more from the overall healthcare systems of the country. We can relate to all of this. In private segment, maybe the order happen may not be the same. It could be slightly different. How can I tell you? Because there is no data. If there is some data, I can give it to you. But unfortunately, I don't have it, Now the question is patient harm what do you say, friends? Is patient harm preventable? Can I see some answers on the chat box? Is patient harm preventable? Is patient harm? Yeah, 100%. Everybody's telling 100%. The inst the Institute of Medicine, now it has a different name. It released a report called "To Err is Human." To Err is Human. This was in 1999 or 2001. I'm not remembering the exact year. It was a very famous report. From there, the study of human factors started. There are two things about human beings. Because we are human beings, we think and we make decisions. Because we are human beings, we can be tired, distracted. So there can be many other things that can precipitate an error to happen. I have not seen any study around human factors where you actually talk about human factors when something goes wrong. Let's talk about medication safety. Do we actually pay attention to the work environment and human factors? I think last year, one of the Annie patient safety fellows even did a study, the fears around medication administration and what are the other factors. So these are, small work that is being done by, few people, which is kind of available. But while they are studying in the college, are they aware that what kind of, environment that they are going to work in? What are all the things that can happen when you are, within a real, work environment of hospital, very busy, sick patients coming, going. There is enough of problems happening because we are human beings and we are errors can happen. So we need all kinds of, safe processes and different way of looking at the reasons errors that are happening. Now, many of you are aware of this very famous story of nurse Wanda in US, where she was actually going to be, coming under the hammer of verdict that she killed a patient. If you just to remind you, what was the story? She was asked to give, mm, uh, not Vercronium, sorry, Versed. Versed is midazolam. Versed is the trade name. So this was a elderly lady for MRI, obviously anxious. So she was asked to give Versed to the elderly lady. So they have these medication cabinets from where you can order drugs. So what happened? She must have typed VER and the cabinet dispensed Vercronium. So unconscious, it seems that she was mentoring, she was distracted with something else. So she took the ampule, she gave the medicine and she came out. MRI is supposed to stay. By the time MRI finished, obviously patient was breathless. No breathing. Resuscitation done, everything done, but the patient could not be revived. It became a criminal case. There was a lot of discussion around many different factors, whether the nurse is accountable for that or not. Even my initial thing was that, the nurse at a personal level, she has a responsibility to self-check, double-check multiple times, whether I got Versed, whether I got Versed. Now, this is a classical story of to err is human. So the story goes like this. This cabinet was malfunctioning for quite some time. It was doing this, So Institute of Safe Medication Practices, they talk about such things to be dispensed only after 5 letters have been typed. I have worked with one system in Saudi, where we could, in the night, we could take out medicines. It's called our, night pharmacy. type in and get, but nothing like that happened there. So we had to go and, put a pen into a hole and then get that medicine. That's a different cabinet. Nowadays, even advanced solutions are available. So ISMP talks about typing at least 5 letters before the medicine is dispensed. So in this, because she typed VER and the, vercuronium came out instead of versed, and she gave vercuronium. So a lot of discussion happened around the responsibility of the organization and the leadership. Finally, she had been, she stood trial, but she was not convicted. But imagine what will be her life for the rest of her life. So much of exposure. People may be thinking that personal accountability is there, but there is even a larger responsibility of the organization and the leadership. See, some of the things that happens in leadership is that when you hear something is going wrong, we don't get our alarm, bell ringing to say, oh my God, today we are protected, but the tomorrow can be worse. So let me look into the situation. Let me see what needs to be done so that this will not happen again. So this is what I am asserting to all of you to think. Don't let anything go, it's okay. So WHO also talks about one more behavior, human behavior, normalization of deviations. That means when you see something wrong today, no big deal. Oh, she's a smart nurse, or today she made a mistake. Let it be, I'll talk to her. If it gets repeated. No, there is nothing called if it gets repeated. You need to have the dialogue then and there. Ask the person why, what can you do so that she will not do the mistake again. I have also faced all these problems that all of you are facing when I was the nursing head. Some things I used to do different. I used to tell my nurses, if you think that you are not safe to give medication, give a call to the supervisor or even call me. Tell that I have too many patients, I cannot give the medication safely. I want to hear that from my nurses. Unfortunately, my nurses will not courage to make that phone call. Why they are not having the courage? Because they are not thinking patient safety is the paramount. If my every single nurse thinks that my patients needs to be safe, anything that is unsafe, I am going to speak up. Do we allow them to speak up? When they speak up, do we shut them up? You just shoo once, then nobody else will talk. They'll say, what's the point? What's the point of talking? Nobody listens. Let it be. Chalega. Koi baat nahi. There must be dialogues and discussion. That is why this, very important and very famous Swiss cheese model. So right here, we talk about all the latent factors. I mean, this is a very nice way of understanding that when you actually look at the root cause analysis, what all should you be actually looking at? This is from the Australian Medicine's Handbook. The factors which are hidden that we don't want to talk about, when you do an RCA, if you have these things written down, what are the latent factors that could have contributed? What are the active failures? Defenses. What was the defense which was available? Was it not followed? Then error producing factors. This is, it is not that, RCA has to be only done by people, process like that. Nothing like that. You can put the thing in, if you ask me, when I looked at this, I said, okay, I will try to put all these latent factors, try to understand, was that a contributing factor? Yes. So one need to read up and understand and do what is relevant and practical, not do things which are only driven by theory. It may not give us the right answer that we need. So this is a fantastic Swiss cheese model where you have created multiple layers of protection. But when the holes get aligned, organizational processes fell short, error producing factors got aligned, active failures from the person themselves, the defenses all failed. So I always tell, Right here, this is the patient. Right here is my assigned staff nurse. If she is smart, if she is thinking, she knows what she has to do. She will be my soldier. She will be my safety soldier who will stop and say, sorry, this cannot happen. It was a struggle for me to get the doctors to sign the, the mark the surgical site. They will not do it and they will insist transfer the patient. So I had to play games to get the doctors to sign. It was in the beginning when the process came in. So I had to plan with my OT manager. I told my OT manager, you refuse to take the patient. Then I told my nurses, if you transfer a patient without the site marking, you will explain to me, not the doctor. They said, doctors will shout at me. So I only give them one answer, call me. You think you cannot talk to the doctor? I would like to be called to tell, okay, ma'am, this patient, no site marking, the doctors are calling. So from both sides, when we started working, we could get some results. So like this, there are many, many stories. I'm sure that many of you sitting here, nursing administrators, you also have that story. So is patient harm preventable? Can be personal, situational, task-related, organizational. Now, I'm giving an overview of this. Idea is that you would, this challenges crash is a very famous story. This is their rocket that crashed in US. When they did the root cause analysis, there were some whispers from the lower level staff saying that there is a glitch. We should, we should talk about, they whispered about it. But the seniors, they said, no big deal. Who is talking about this? No big deal. And finally, so many people died in that crash, Challenger crash, right? So that is where when whispers about unsafe practices are neglected or we close our eyes, it can then, so organizational responsibility is paramount. Then making sure the task that is given to them is the task is given to the right person, the right time, with the right training, with the right background. Are the situations being managed? Then at the personal level, am I following all the SOPs? So applying human factors is very important because this talks about communication, leadership, teamwork, workload management, situational awareness, and decision making. So are we, when we are, planning our CNEs and when we are educating our nurses, are we keeping these things in mind, or we are just doing the induction because there is a need to give induction? If we always talk about patient safety for your 7 days or 10 days, for everything we are talking about patient safety, I am very convinced that, somewhere it will make a, you know, unerasable mark in their head that we are born to be safe nurses. We have the commitment, we have the responsibility to give safe care. So the common cause of sentinel events, miscommunication, critical thinking, this is from the document. Staff vulnerabilities. The vulnerability is not only about the patient and family, the staff also. When the staff had some major personal tragedy, do we think that whether this nurse is safe to work in the environment that she has been assigned? Question to ask ourselves. Healthcare being an effective team player. I know the time is running out, so I'm going to run a little quickly. Advocate for patients, communicate effectively, work as a team, keep a positive attitude, deliver top quality care, maintain your integrity. Now, this is how to show professionalism. Now, each one becomes a topic by itself. The college faculty and, the induction, when induction happening, are we able to focus on the professionalism? Communication skills, oh my God, it's a never ending, topic. And usually, I'm going to skip this video. I'm going to talk about all this. I am very fond of these tools, where you can give lecture for very, very long time. But make it simple for them to understand. When are these tools used? Show them how it is to be used. Tell them what is the, potential for making error within this, knowing full form of, again, from my own experience. Even in the virtual world, when I get my participants to do a role play, I don't get it 100. So healthcare is a very complex system. It is very important as a team. We should know that what is more important, what needs to be practiced. Now, talking about learning from mistake, I always tell, there are so many errors that have happened around us in healthcare. Why do we have to make everyone to make their own mistakes to learn from it? That is not smart, right? We are saying, so if I had 400 nurses, nurse made a error. Maybe it resulted, maybe not. If I don't talk about it, it becomes normal for the remaining 399 nurses. And I am taking a risk of allowing the 399 nurses to make that mistake once because I didn't do anything to this nurse. They will ask me, no, when she did, you didn't do anything. It happened with me, now you are doing something. So,
work somewhere else and then come.
We should always
experience and then come. Or else you
who is speaking?
Where?
Keep yourself muted, please. I'm trying to see who is the person speaking. Okay. So this talks about it takes only 0.1 second to recognize an error. And there is a conscious consideration that, they could pick up the error. So experience creates heightened awareness. Now, all the young nurses, can we wait for them to experience 10 years before they learn? So that is our responsibility to give that experience to them. I'm doing my bit in whatever way that I can to bring that awareness to all of you so that you can take this as a cue. All these things, these are things that we need to explain to our nurses how this can happen. And as a nurse leader, I design processes in such a manner that these things are getting addressed. That is my smartness. So this is very, very important. And these are our basic topics, which are very important to be taught to all the upcoming nurses and also the existing nurses. Your mid-level managers, supervisors, if they are not thorough with this domain, there are no teaching moments because I will not see something that I am not trained or I am not aware. So when I see something wrong, I don't know that it is wrong. So I will not make an effort to correct my nurse or teach that nurse at that particular time. So I am losing my opportunity. Now, strategies to learn from medical errors. You can talk about the events. You can immediately debrief. You can talk to the people. You can do mentorship. You can give constructive feedback and simulation of those error scenarios. This is very, very powerful that if you can do simulation, and it is possible to do without mannequin also, so that we can live up to this, promise that we don't want to do sick, no harm. So there is an article around this is called roving patient. Roving patient means no mannequin, nothing. The education department takes the event that happened in the hospital, they create a drama around it, and they go to every unit in between the shift and they enact the thing, ask the team members to tell what went wrong, what could have been done better. That is a far more effective educational session than calling them all into class and then, telling the slide, this is what happened, these are the reasons, this is how you prevent. No, adult brain wants you to engage them so that they can become aware of it. So all this takes a little effort from the people who are planning. It's very easy to put together a presentation and talk about it. I mean, I like to, give real time scenarios and, stories so that you make sense of what I am discussing. Now, if Mr. Jaydeep was here, he would have talked about this. Now, if you want to become certified in simulation as a trainer, there is this certified trainer course happening in Gurgaon in November. So if anyone wants, if you have a passion to convert all learnings into simulation-based learning, the principles can be used by various different manner. Today, I did not engage anyone to get into role play or anything with me because this is a sensitization webinar, and so this is what it is. Tomorrow, when you come, maybe you will see some role plays that me and Sati is going to do. Sati is the the managing director of Tagore Institute, with whom I have signed an MOU for improving the English communication skills of nurses and nursing students. And we are designing very relevant programs, which can be taken by in batches. We will talk about it tomorrow. So please remember, you can only manage with what you can measure. This is also very important. And what you measure needs to be monitored. So you can only measure what you are monitoring, and what you are measuring only you can manage. Now that's the takeaway for any quality assurance program. Around anything, these are some very important theories that you should know. So I did talk about this already. I'm sorry, I'm going back. All right, let me move forward. Sorry about that. So with that, I also want to invite you, your students and everyone to go to Signia Healthcare Academy. And if you go to this link, I hope you can see this link. If you go here, you will find this course, which is very free. It is called IPSGs Made Easy. This is a free course, nothing to be paid. And there are 2 modules, and anybody can go and learn online. And you can give the, test exam. It's a small quiz. And after that, you can download your certificate. All you have to do is you need to tell them, come back and, show me the certificate. So some information, some learning is happening without you investing any time. That video is about all the IPSGs. The 7th one I add there because JCA is insisting on this. Reduce the harm associated with clinical alarm system. Each topic is very important. So, ladies and gentlemen, thank you for being with me so far. Some of you have dropped off. I know you have other commitments, but welcome back tomorrow at 7 p.m. when I talk about spoken English, nice to have or must have. I'm going to have the Miss Sati, as I told you, and we'll talk about English, and then we talk about the upcoming courses. So please feel free to share this with your team members to go to signiahealthcareacademy.com, take the online course, and then they can come back and show you the certificate, because you don't need to do anything about it, right? So these are opportunities I am trying to create for nurses and nursing students. Now it is up to you how much you want to avail. So thank you so much to all of you for being here. I took 10 minutes extra. We started 5 minutes late, but thank you for being here. It is being recorded. We will upload it on the Signia Healthcare YouTube channel if anybody else wants to watch it. So I'm going to stop the recording, and if anyone has any comments, we can open the session to the public and what they want to share.